Alzheimer's Association. Oh, gotcha. Hello, welcome to the Alzheimer's Association's virtual panel discussion regarding health equity. I'm Adrienne Holden, Regional Health System Director with the Alzheimer's Association. And today you will hear from a keynote speaker from the Alzheimer's Association, along with Kansas City and St. Louis public health officials, examining racial and ethnic inequalities in health, with an emphasis on addressing awareness and access issues. I would like to say and take this opportunity that we've been able to have our regional lead support us, and the regional lead's name is Stacy Tulivas, and we've also had help in these efforts with the diversity and inclusion team members of the Greater Missouri chapter and Kansas City Heart of America chapter. Next, I would like to introduce our moderator for today, which is Cara Anthony. She is a Midwest correspondent for Kaiser Health News, a native of East St. Louis, Illinois. Her work has been published by the New York Times, Time Magazine, and National Public Radio. Cara co-moderated US Today network events during the 2016 election, and her six-part Belleville News Democrat series titled Then I Knew About Racism in America was nominated in 2018 for a Mid-America Emmy. She is a graduate of Tennessee State University, and we would like to thank you and welcome you, Cara, for moderating this virtual event today.
Thank you, Adrienne, and welcome everyone. Thanks for having me. I'm delighted to be with you all today. For the next hour, we will discuss health equity, Alzheimer's research, and early lessons that have been learned during the COVID-19 pandemic. But first, before we get started, I'd like to read a quote from the late Dr. Martin Luther King Jr. It'll kind of bring us all in and remind us why we're here today. And that quote just simply says, "Of all forms of inequality, injustice in healthcare is the most shocking and inhumane." I thought about that quote getting ready for today's discussion, and I hope this conversation can move us all forward. Now for the introduction of our speakers. First, I'd like to introduce Dr. Carl Hill. Dr. Hill is Vice President of Scientific Engagement for the Alzheimer's Association. And in this role, he oversees strategic efforts to create global awareness of the Alzheimer's Association's international research program. Dr. Hill leads outreach for all staff for at least 75 of those chapters, and he hopes to grow an understanding of the association's role by accelerating Alzheimer's research. And to advance the association's scientific agenda, he disseminates knowledge of the organization's research through key events like this one today. Thank you, Dr. Hill, for being here. Next, I'd like to introduce Dr. Frederick Echols. Dr. Echols is the Director of Health for the City of St. Louis, Missouri, right here where we are based today. Dr. Echols earned his medical degree from Boston University School of Medicine. He also completed postgraduate training with the United States Navy in Portsmouth. I just want to say personally, thank you for your service in serving our country. Also, Dr. Echols has served as the Chief of Communicable Disease for the Illinois Department of Public Health, the Director of Communicable Disease Control Services, Vector, and Veterinary Programs for St. Louis County Department of Public Health. Thank you so much for being here with us, Dr. Echols. We look forward to hearing from you. Next, I'd like to introduce Antonio Miras. Antonio was born and raised in Galicia, Spain. He studied sign language interpretation there and graduated with a specialized degree in language interpretation. And I'm sorry, I'm going to rewind that back because I want to make sure I'm getting his degree right. He has a specialized degree in sociology for the deaf community interpretation and for deaf and blind people, which is just such a special specialty, and I'm so glad that he's with us today. Since 2016, Tone has been supervising a team of amazing community health workers whose focus has been able to assist people in the African American community, refugee community, and Latinx communities. Tone is also the co-chair of Kansas Kansas's Coalition for Healthcare Workers. And for 3 years, he's been empowering healthcare workers across the state by speaking at programs just like this one today. And we're so glad to have you here with us, Antonio. So first, I'd like for Dr. Carl Hill to get us started and to talk about research and the scientific advancement that's going on, even though we're in the middle of a pandemic. Dr. Hill, it's right to you.
Absolutely. Thank you so much there, Cara. This is great to be here. I'm going to share my screen quickly with hopes that you can see that. So what a tremendous opportunity. I'm going to go really quickly here, Cara. It's an honor to be here. Thanks to the whole team, Adrienne Holden, who is a health equity expert in her own right as a research champion and health system director for the Alzheimer's Association, Sarah and Jennifer, everybody who made this happen today. So I want to spend some time, talking a little bit about the landscape of Alzheimer's and dementia science, some highlights in early detection, and I want to get into some discussion around health equity and health disparities research. So I'll be moving pretty quickly because unfortunately I missed the prep call and I've got less time than I thought I had, but I want to make sure I get the message across here. So just a couple of weeks ago, we had just a fantastic Alzheimer's International Conference, which took place virtually. And we had over 33,000 people attend and some wonderful discussion around health equity research. So just a tremendous chance to talk about health equity and health disparities. Just a reminder, the Alzheimer's Association is a global organization working to advance care, support research across the world. When you look at that emblem right there, there's research is great to discuss during our Alzheimer's International Conference, during panel discussions and to publish in high impact journals. But we know that the best impact of research is when it translates to people's lives and it protects public health. And it really protects the people, and it enhances the care and support for our loved ones that are suffering from dementia and Alzheimer's. So this is really important. I wanted to focus on the theme of diversity today, right? And so coming from the National Institutes of Health, I have been really inspired by diversity as an underlying concept for almost everything that we do, right? And when we think about the hallmarks of the disease, Alzheimer's disease is a fatal disease. It's characterized by two abnormal proteins, which are amyloid plaques and tau tangles, which lead to brain cell death in the area of the brain that retains and forms memory. So even the characterization of the disease itself is diverse in three hallmarks, which is amyloid plaques, tau tangles, and neurodegeneration, or otherwise known as cell death. When you look at the picture here, this is Dr. Alois Alzheimer's, and next to him is Dr. Solomon Carter Fuller, who was the first African-American psychiatrist in the United States. And he graduated from Boston University. And I think I heard that one of my fellow panelists graduated from Boston University's medical School of Medicine. So Dr. Solomon Carter Fuller graduated way back in 1897, first African-American psychiatrist in the United States. And because of the racial discrimination that was occurring at the time in 1906, he was unable to practice. So the only job that he could have was to perform autopsies, and he did really well. He became quite proficient in performing autopsies, and Dr. Alois Alzheimer's recruited him to his lab in Germany to help him understand what was going on in the brain and to help what we know now is characterized as Alzheimer's disease. So this research area has a legacy and a history of diversity, inclusion, and really seeking diverse perspectives when thinking about some of the tough questions as it pertains to Alzheimer's disease and other dementia. So diversity as an underlying perspective is very important. Just some level setting here, dementia is a syndrome. It's a collection of symptoms due to biological changes in the brain. That was the diverse perspective that Dr. Alois Alzheimer's was seeking when he sought to characterize this disease. But Alzheimer's is the most common cause of this dementia. There are other types of vascular, Lewy bodies, frontal temporal, but that's just some level setting information. As many of us know, currently there aren't any therapies that can cure Alzheimer's. There's some drugs that are listed here that are available to temporarily improve symptoms, but we're making great progress in developing new and better therapies. And this is really important because the job that caregivers are doing in this country for those that are suffering with Alzheimer's is tremendous. So I really like to emphasize the point that our research enterprise is pursuing therapies that can improve the well-being of those that are affected with Alzheimer's right now, because that is very important for our loved ones and caregivers who are doing just a tremendous job in this area. Just a quick announcement, if you're following the news, take a look at aducanumab, which is a drug that has gone all the way to FDA for priority review. So it has made it through phase 1, phase 2, phase 3 clinical trial testing. And what's important about aducanumab is that it's the first drug that has gone this far in over 10 years that treats the underlying causes of the disease. So what I just mentioned were treatments that would improve well-being. Well, this is a drug that targets the amyloid in the brain, and the FDA is reviewing this particular treatment right now. So, if you get a chance, I'll give you some information at the end of the presentation to look up aducanumab, but this is a very important announcement in the field that I think is going to be quite important. But we can't wait on a drug or a treatment, right? And so we know that Alzheimer's and dementia falls along a continuum of cognitive impairment. And this continuum is characterized by the fact that mild cognitive impairment is a known risk factor for dementia. So everyone who experiences dementia passes through mild cognitive impairment. What does that mean? That means that if we can prevent new cases of mild cognitive impairment, then we can prevent new cases of dementia. So this really gives us hope for thinking about ways to really reduce risk for Alzheimer's and other dementia. There's an important Lancet International Convention on Dementia Prevalence, Intervention, and Care that came out with the fact that there were a number of modifiable risk factors that were important for reducing risk for Alzheimer's. I won't go through every one of them, but there's education, hypertension, obesity, hearing loss, depression, diabetes, a number of lifestyle factors that are so important for reducing risk. And that gives us, why is that important? Because that gives us some real hope in terms of things that we can do to reduce our risk while we maybe wait for this treatment that the FDA is reviewing right now. So just some quick facts and figures that I think are so important. Alzheimer's is the 6th leading cause of death. More than 5 million Americans are living with Alzheimer's. 1 in 3 seniors dies with Alzheimer's or another dementia. As I mentioned, there's 16 million unpaid caregivers who are doing, I think, just heroic work in taking care of loved ones that are affected by Alzheimer's and other dementia. And then in 2020, Alzheimer's and other dementias will cost the nation $305 billion. And by 2050, this could rise as high as $1.1 trillion. So no matter how you look at this, this is a public health priority, one that deserves a very specialized attention. In terms of advocacy, the Alzheimer's Association is leading the way in terms of influencing and advocating more research, more funding at the NIH level, at the federal level for Alzheimer's research. If you look here in 2011, there was $448 million allocated for Alzheimer's research. This fiscal year, there was $2.8 billion at NIH for Alzheimer's and related dementia research. This means this is the golden era for Alzheimer's research. The Alzheimer's Association has its own international research grants program, where we're currently investing over $200 million in 590 projects around the world. So what's different about what the Alzheimer's Association can do than the National Institutes of Health is fund international researchers to do rigorous research. So the point that I'm making here to you is that this is a special time in Alzheimer's disease research with many advances and our opportunity to fund many investigators around the world. There is a disparities issue as it pertains to Alzheimer's. So I mentioned more than 5 million Americans are living with the disease. 2/3 of these are women. African Americans are 2 to 3 times more likely to develop the disease than white Americans, very important. And Hispanic Latinos are almost 2 times more likely to develop the disease. So there's an important disparities component that these researchers in this golden area must consider for achieving health equity. When we define health disparities research, it's the investigation of differences at a population level. And there are a number of, I think, levels of analysis to think about health disparities research at the environmental, sociocultural, behavioral, and biological levels, right? So this is defined by the National Institute on Aging. When I think about health disparities research, I think about sociology, right? And the ways in which we see differences. And so Max Weber was one of the founding philosophers in sociology, and he really honed in on the individual, right? And so when we think about the interplay of a treatment, like aducanumab from Biogen, and then lifestyle factors, the lifestyle interventions, or what we in public health call health behaviors, the way that people live their lives. And some important research that came out of that Alzheimer's International Conference just a couple of weeks ago was that higher body mass index may be associated with higher late life dementia risk. So what does this mean? This means that physical activity and our diet and nutrition play a part in our late life dementia risk, the things that we can control. If you're using Max Weber's analysis of differences and disparities in something like in a health outcome like Alzheimer's or another dementia. And this is consistent with some research that's very important. So the Sprint Mind study just a few years ago was the first study to demonstrate a reduction of new cases of cognitive impairment. So in this way, when the study investigators were able to treat and control systolic blood pressure to 120 systolic, there was actually a reduction in mild cognitive impairment, a reduction in dementia. So this was the beginning of us being able to see that lifestyle does matter. The Alzheimer's Association is currently, because of that study, is supporting, planning, and implementing the U.S. Pointer trial, which stands for the U.S. Study to Protect Brain Health Through Lifestyle Intervention to Reduce Health. And this is a 2-year multi-center randomized clinical trial, and there'll be 2 components, a self-guided and structured lifestyle group. So this is going to be an important opportunity for us to look at the recipe between physical activity, nutrition, cognitive stimulation, and health coaching, right? So those that get the structured lifestyle intervention, we want to see if their risk for mild cognitive impairment or dementia is reduced because of receiving that intervention. So this is going to be really important, I think, for understanding the influence of lifestyle on risk for Alzheimer's or another dementia. That U.S. Pointer trial is not alone. There are many trials around the world that are beginning to look at lifestyle factors. So we can't wait. We're supporting and funding researchers who are moving clinical trials through different phases to understand how a drug might work. But we can't wait on that alone. We know that lifestyle does play a role, and there are many trials around the world that are looking at the influence of lifestyle on risk reduction for Alzheimer's or another dementia. And again, I underscore this. Why is this important? It's important because there are things that you can do to reduce your risk of dementia, especially regarding cardiovascular disease risk factors, and that's really important. So that's something I want you to keep in your mind as I continue forward. Cardiovascular risk factors. Another way to think about health disparities research is kind of class differences, right? So Emil Durkheim was another founding sociologist who said the aim for a civilization beyond that made possible by the nexus of the surrounding environment will result in unloosening sickness. So what he's saying is, if you don't understand the class, the influence of social class in society, then you could be unloosening some sickness and missing out on understanding the social influence on the individual. And there's some research that supports that, right? So one of our awardees in the Alzheimer's Association International Research Grants Program, Dr. Al Hazori, took a look at a certain study with Mexican Americans, and she found that those with the higher SES, and SES is education, occupation, income, a composite of those factors, those with the highest SES were able to stay dementia-free the longest, right? So that's really important. It calls into play the importance of resources like education or maybe or quality healthcare or income or support. So really important to think about the influence of society, the social forces on risk for Alzheimer's or another dementia. There's been research that looks at the role of education in the association between race, ethnicity, and cognitive impairment and dementia. And it found that as education increases, risk for Alzheimer's decreases, right? So really important, I think work here. And there was a really great presentation during AAIC a couple of weeks ago from Dr. Jim Manley, who took research like this a step further to understand the quality of education, right? Early life education and how that influences dementia risk late in life. So some really provocative work, I think, in the disparities realm. And then, we know that I mentioned that the Lancet International Commission on Dementia Prevalence, Intervention, and Care came up with those factors. They added 3 additional factors during this year's AAIC: air pollution, traumatic brain injury, and excessive alcohol use. Really interesting because the traumatic brain injury and excessive alcohol use really, play into our understanding of health behaviors and lifestyle factors. But air pollution is quite intriguing to me because it says that where you live, the places where you live, right? Some of the environmental factors and maybe some policies that are local policies that are so important may have some influence on risk for Alzheimer's or another dementia late in life. Really interesting stuff. So it begins to expand our understanding of health behaviors and lifestyle. And then I think another way of thinking about another lens for health disparities is that which W.E.B. Du Bois really proposed, and he was the first African American sociologist to graduate with a PhD in sociology from Harvard University. And he mentioned something about stress and the stress of life and something about being African American in the United States. And so it's really interesting. So when we look at some data from Jamal in 2008, I mentioned the relationship between education and Alzheimer's and dementia, and education as a factor in SES, pretty much says the more education you get, the better your health. That's how things should go, right? But when we look at heart disease here and comparing blacks and whites, the ratio is inverted, if you will. So the more education, the higher the black-white ratio. So let's break this down just a bit. So as number of years in education increases, the black-white ratio increases for heart disease, for deaths from heart disease, for women, for black men and black women. So this is quite intriguing when you think about how important cardiovascular outcomes are for late life Alzheimer's and dementia risk. There's a connection between what's good for the heart is good for the brain. So when you take a life course perspective, we know that those outcomes, those cardiovascular outcomes, are very important. And education, in this case, is not protective. It's not protective for African Americans. So this is really interesting because I think it points to Du Bois's point that there's something around stress and being in a certain racial ethnic group in this country that could increase risk for a number of health outcomes, maybe including Alzheimer's and other dementia. So when you think about that U.S. Pointer trial that's looking at that recipe of lifestyle factors, the health behaviors, there's something more than people's individual choices. There are other factors that influence the way a person might live his or her life. And right. So I had a chance to work with the National Institutes of Health, and we developed a research framework that try to expand the number of factors at the environmental, sociocultural, behavioral, and biological level. So when you think about this from a dementia science perspective, we're really proposing here that there are environmental factors, maybe air pollution in the way that the Lancet Commission suggests, sociocultural factors, that influence behavior. So, excessive alcohol use may not be just a person's individual decision. It may be influenced by the stress that W.E.B. Du Bois proposes, or air pollution in the way that the Lancet Commission proposes. But there are a number of factors that I think are at play for the way people choose their lifestyle and their health behaviors. And that's important for understanding how those amyloid plaques and tau tangles are developed in the brain. So what are the pathways, through behavior for health disparities in Alzheimer's and other dementia? We're funding some really important research. This is Dr. Megan Zulsdorf, who's at the University of Wisconsin, who's taking a look at the weathering hypotheses. And that is, as people live their lives in the early life adversity and the stress that they endure over their lives, if that has some influence on risk for neurocognitive outcomes that include Alzheimer's or another dementia, really, I think, innovative ways of taking the health disparities literature. Arlene Geronimus and others developed this weathering hypotheses and placing this in the Alzheimer's and other dementia research enterprise. This is a fabulous, I think, way of thinking about this from a life course perspective, and I'm really excited about more work here. Of course, in order for us to find out and analyze data as it pertains to disparities for African Americans and Latino populations, we've got to have diversity and inclusion in the clinical trials. And so this chart here shows that there's a severe lack of African American participation in federally funded clinical trials. Why is this important? African Americans are disproportionately affected. They're the most affected racial ethnic group in this country with Alzheimer's and other dementia. So for this particular group, African Americans, to not be included in the trials, I think really is a call for action for all of us that are working in the community, that are working with clinical trials, that are working in public health and in policy. Really important. And the ultimate outcome, could be that once that particular treatment is reviewed and hopefully it receives a rigorous review by FDA, we want it to be effective and relevant for not just Black patients, but for all people, right? That's very important. So we've got to be sure that we are recruiting and retaining diverse groups into Alzheimer's clinical trials. What are some important ways to think about recruitment and retention? I think resources are important, being sure that there's funding for recruitment, adequate funding for recruitment, training so that investigators can be creative and they can partner and engage with community-based organizations that are trusted in African American and Latino and Native American communities, Asian American communities, very important. And then we've got to evaluate strategies that work, right? And share those strategies with others in this particular field. So this is really important. And then all of us as a nonprofit funding organization like the Alzheimer's Association or the NIH as a federally funding agency, holding investigators accountable for their plans for diverse recruitment and retention. So some things to think about as we move forward. The Alzheimer's Association has a great resource in this area called Trial Match. It's like a dating kind of match service, except you don't get a chance to go out on a nice date for a nice meal. But this is a great chance to find out clinical trials that you or your loved one may be eligible for in this space. So visit alz.org/trial match to get a sense of the clinical trials that you or your loved one could participate in, because this is critical and so important for helping us to increase diversity and inclusion in these clinical trials. So important. So in summary, the Alzheimer's Association is a global leader for Alzheimer's and dementia science. This is an exciting time in research. This could be the golden era, if you will, for research with the funding that we have and the influence and the ways that we can get early career investigators in this field is so important. There are new tools for detection and diagnosis. There's a growing diversity. There's that guiding principle of therapies and tools under investigation. We need resources and innovation for diverse participation. But we know that this research, this new research leading to a future of therapy that combines not only drugs but modifiable risk factor interventions, which is so important. And why is all of this important? I'm ending up here, but if we develop a treatment by 2025 that delays the onset of Alzheimer's by just 5 years, 5.7 million people expected to develop Alzheimer's in 2050 would not. And it would be, I tell you, it would be something if we were able to achieve that, but the disparities in Alzheimer's were to persist, right? So when we think about health equity, this is achieved when every person has the opportunity to attain his or her full potential, you know, and that should not be prevented by social position or socially determined circumstances. And the CDC has defined this as being a very important goals for health equity. We had just a tremendous presentation, and if you're a member of the Alzheimer's Association's iStart, I will share information in the chat about our iStart, because we have much of the content from AAIC a couple of weeks ago still available for those that would like to view it. That was just a great presentation by Dr. Lisa Barnes, who's at Rush University Medical Center. And she really made the point that it's time for a paradigm shift, right? And so when we're thinking about Alzheimer's and other dementia disparities, traditional risk factors studied in predominantly white samples provide useful information for understanding disparities, but we must incorporate lived experiences for diverse participants. And that means we've got to understand the environmental and sociocultural factors that influence behavior, that may influence the behavior that ultimately have an impact on amyloid plaques and tau tangles that form to influence neurodegeneration and the development of Alzheimer's and other dementia in our communities and in our populations. So the legacy here, I mentioned it before, we are in a research enterprise where Dr. Alois Alzheimer's in 1906 was a champion, I think, of diversity and inclusion by including Dr. Solomon Carter Fuller. They both had a novel and a diverse perspective. And when we think about this paradigm shift that Dr. Barnes mentions, it would be aligned, and it would be certainly reflective of the way that this research enterprise began, and our job is before us to accomplish and to do it. So if you have questions, my colleagues are available all day, every day at 800-272-3900. They never sleep, and all of a great resource for information is alz.org. And I'm looking forward to the panel discussion and the questions. So I'll turn it back over to Cara. Thank you.
Thank you, Dr. Hill. That was really rich information. And I'm looking forward to going into the Q&A section where people will be able to interact with you more and learn more. I personally would love to learn more about the clinical research trials and really getting people of color involved in those trials. And so we'll talk about that a little bit. I just want to give a reminder to our audience. We are over 100 strong, which is great. Feel free to drop your questions in the chat box below. And I'm even going to say, if you want to tweet at me at Cara R. Anthony, or send a tweet to ALZ Greater MO, we can get your questions in that way. And so we'll keep the conversation rolling, and really looking forward to the Q&A section. So thanks again, Dr. Hill. Next, we'll have Dr. Frederick Echols, who's going to come to us to talk a little bit about some of the early lessons learned during the COVID-19 pandemic, particularly as it relates to how we are communicating with Latinx and Black communities. And so, Dr. Echols, I'm going to turn it right over to you. Oh, you think you're muted, Doctor? There you go.
Thank you for this opportunity. As Dr. Hill alluded to during his discussion, a lot of the disparities that we're seeing in during the COVID-19 pandemic, they're not new. So these are pre-existing conditions that have been exacerbated by COVID-19. And so one of the things that we had to do as a health department was really refocus and look at the root cause of the issue of the disparities, and figure out a way that we can effectively ensure that our most vulnerable populations within our jurisdiction have the information that they need, as well as the resources that they need to prevent the spread and slow the spread of COVID-19 in our jurisdiction. So early on, we noticed that COVID-19 was disproportionately impacting the African American community. The first 12 deaths in the city of St. Louis were all African American, and early on, roughly 80 to 90% of all of the cases were African American in the city of St. Louis. And so we realized early on again that this was something that was going to hit our most vulnerable populations, particularly people of color in our jurisdiction, really hard. And so we had to figure out how to effectively communicate information to them. One thing that we did is we partnered with other organizations across the system because we realized, one, that we could not do it alone. As a government agency, there's often a lot of mistrust, particularly in communities of color, when you have an organization that's affiliated with the government. And so we had to reach out to those community-based organizations, those grassroots organizations who have built trust over time with those populations to get the information to them. That was one part of it. The other part was making sure that the language that we used was simple enough that anyone in our community can understand it. And we were developing communications and different materials is only effective if the community can understand the information. And so we made sure we use plain language. We also looked at, we're mindful of the health literacy levels across the jurisdiction to make sure that we weren't using complex terminology or really technical terminology, because that, again, oftentimes is not well understood in our most vulnerable populations. So those are two things. And then we took it a step further. We used data that had been collected over time to identify the most vulnerable areas within the city. So we identified the 15 zip codes that had the highest level of poverty, the 15 zip codes that had the highest percentage of uninsured individuals, and made sure we implemented a grassroots approach to make sure that individuals got the information that they needed to protect themselves. Once that started, we began to get feedback from the community. And the feedback that we got was, information is good, but we need resources. So when we think about our most vulnerable populations, we think of, the need for face coverings and need for other resources that we oftentimes take for granted. But for some individuals, that could be the difference between a meal or their rent. And so making sure that we partner with organizations to get the resources that they need to the community, in addition to having the information, was really critical. But then using a variety of different platforms was also important for us. So traditional media works well for those individuals who have access to, a phone or the internet, social media. But oftentimes our most vulnerable populations do not have access to those resources. And so that's why we had to implement a grassroots approach, meaning that we had individuals going out into the community, canvassing different areas, going door to door to engage individuals directly that we knew were had the highest risk for contracting COVID-19. So those are some of the measures that we have implemented to kind of bridge the gap and address some of the disparities in the city of St. Louis. But we also had to do, one other thing that we had to do is also talk about testing. So when we talk about testing and making testing widely available, there's, again, mistrust or distrust amongst government agencies as well as the health community, because the health community has also been a part of the system that has disenfranchised and ostracized communities of color in the past. And so we had to do a lot of messaging around, what COVID-19 actually is, why the testing is important, and why particular communities in our jurisdiction need to take advantage of the testing that's available. Then we also had to make sure that we removed all barriers for testing. And this was important. Again, we talked about our most vulnerable populations, those who don't have the resources to cover the cost for testing. So we had to make sure that testing was available at no cost. So we've been doing that for the last 4 or 5 months to make sure that everyone within our jurisdiction had equal access to the services needed to, one, identify the COVID-19 status, as well as implement the measures needed to mitigate the spread of COVID-19. We have a lot of work to do. As I've mentioned before, so a lot of the pre-existing issues are really being exacerbated now. And so we have to use this opportunity to really press the reset button and create a new foundation, a stronger foundation that really supports the development and the health of our most vulnerable populations. As I've said before in a lot of my meetings, we're only as strong as our most vulnerable populations. And so if they're suffering, the system is suffering. And so we have to make sure that we have a platform in place where they can thrive and achieve optimal health. as we move forward, we also not only looking at what's happening during the COVID-19 pandemic, we also have to do a better job of understanding the history of the jurisdiction where we live. So there's a lot of inequities that have been perpetuated over time. And as a public health agency, we have to make sure we understand the history so we can understand how we need to move forward and create a clear vision for our community.
Thank you, Dr. Echols. One thing that I'm curious about, and it's just looking forward and moving forward, as there is a vaccine that may become available in the next few years, we talk about access issues as it relates to testing. And I recently traveled to the Boot Heel of Missouri, southern Missouri, where testing is, there's still a huge access issue down there. Are you worried at all about what that's going to look like once a vaccination does become available, and who will be able to get it, you know?
So public health, that's an excellent question. So public health agencies are advocating for the availability of a vaccine that can be made available to everyone, regardless if someone is able to afford it or not. There are some additional questions that are being raised during this time. As you may know, there's an emergency use authorization for over 200 vaccines that are in the pipeline. So typically, it will take a vaccine 3 to 4 years before it's actually approved and made available for the public. At this point in time, we have hundreds of vaccines that are in the pipeline that are going through phase 1, phase 2, and phase 3 simultaneously. So what does that mean from an evaluation standpoint? Do we know enough about the side effects and potential complications of these pharmaceutical interventions before they're being released to the public? And so that's one thing as a public health agency, we have to make sure that we have sufficient evidence to make sure we're not doing more harm to the populations that we're charged to serve and protect. And so as we work closely with our federal partners at CDC, NIH, as well as our local partners and state partners in the state of Missouri, we have to make sure that we're communicating accurate information to the public so that they can make an informed decision about whether the COVID-19 vaccine is appropriate for them. According to the CDC, there's potential for a vaccine to be approved by the FDA for use by as early as November. And so that's a really short time frame. We haven't even studied COVID-19 for a full year yet, but a vaccine may be available. So there's a lot of questions around the ethics of the process that's being implemented now. But more importantly, for the public health agencies, we have to make sure that we are communicating accurate information about what the vaccines are, what it means for health of our community.
Thank you, Dr. Echols, and please stick around. Dr. Echols is going to stick around for the Q&A section. Again, reach us via Twitter, reach us via the Q&A box below, because I also have more questions about just the history of testing and vaccines. There's a long history of mistrust, unfortunately, in the Latinx and Black communities that we can hopefully discuss a little bit at the end of our session together here. But next, I want to thank you so much, Dr. Echols. I want to reintroduce Ton, who's going to talk to us a lot about what's going on in the Latinx community as it relates to COVID-19. It is so important that we reach all communities, and so I'm just going to turn it right over to you.
Cara, thank you so much. And Adrian, both of you, thank you so much for giving me the opportunity for presenting about overcoming the medical and social challenges on the Latino community with COVID-19. So in order to talk about overcoming those medical and social challenges, I wanted to talk a little bit about the challenges first. So I divided the challenges into medical and social. So I'm going to begin with medical. So regarding to access to care, something that we have noticed is that many of the Latino folks that are working with us, they don't have health insurance because they don't qualify or because they cannot afford it. And so that is preventing them to get access to medical care. And also they are afraid of the medical bills like everybody else, right? So you go to the hospital, you go to the emergency room, you don't know how much you're gonna be billed for that. And they don't wanna have a bill on their backs and having to pay that. So the second part is the immigration status not being regulated. There are many of our patients that because they don't have a social security number, they are scared to death to go to a doctor because many times they ask for a social security number and that doesn't mean anything. That doesn't mean that they're going to be reported, but the fear is out there. The third one is the language barrier. You cannot imagine how many times we have been helping patients, especially now during COVID-19, where they cannot go to an appointment in person, or at least at the very beginning. And so we spend like 1 hour on the waiting room on a telehealth call. Doctor is there, patient is there, and the surprise is that the interpreter is on the phone. So when the interpreter is on the phone and the patient is on a video call, the connection, the sound is not good. So making the medical appointment not very successful, and having like lack of understanding between the doctor and the patient. So we're working a lot on those things. There are many patients that they don't even know, and this is not just because of the language barrier, it's about education, how to set up an appointment, like a medical appointment or even a telehealth appointment. More things, patients that are waiting until the very last minute because they get sick, they get very, very sick, and then it's that moment when they reach out to a doctor. Sometimes when that moment comes, it's just already too late, especially related to COVID-19, because many of these patients already spread the virus to the family members, the friends that they have, and when they go to the doctor, unfortunately, and we had several cases of this, it's very late. So we also heard that the Latinos became the minority with the most number of positive cases of COVID-19. And so we wonder sometimes, and I will talk about this on a social level, but why is that happening at this point? There is also distrust of the healthcare system of the United States of America compared to the care that they receive on their countries. And it is not because the care that is here is worse or is better. It's simply because they don't know it. They don't know how to access, and therefore there is fear to the unknown. So regarding to the COVID-19, there are many organizations, and this refers a little bit to what Dr. Echols was saying before, organizations that they are doing flyers in Spanish, like the health department, safety net clinics, hospitals, community-based organizations. And those flyers in Spanish are amazing, are really good. But those flyers sometimes don't make it to the community. So they are given to a patient, the patient gets the flyer, they keep it, that's it. And it's not being shared in the community. The information that the patients are missing about COVID-19 is how does it spread? What are the symptoms that you get when you get COVID-19? The PPE, so masks, gloves, hand sanitizer, how do you use it? Social distancing, what is that? You know, how do you do social distancing? Do you have to put a mask? Do you not have to put a mask? And also where to get tested. There are many patients that they don't have any clue on where to get tested. They don't know if there are events or clinics or pop-up testings. And especially at the very beginning, not so much now, but some of the testings had a cost involved. So patients had to pay for it. And many of the patients couldn't even afford that. So that's on a medical side of it. The social part of it, there are some organizations that they feel like they cannot provide services if the patients are undocumented. And legit, there are many times where if you are applying for Medicaid, Medicare, and things like that, you actually do need a social security number. But there are many other services that you do not need a social security number, and they get denied to get those services. Same thing with pantries that are asking for social security numbers to patients, and they say that it's for tracking purpose. And so the patients, when the Latino community, when they get asked the social security number, and if they don't have it, they get scared. They're not gonna come back. Even if they are starving, if they are needing that food, they're not gonna come back to get that resource. So like everybody else, the Latinos continue to work even during the pandemic in being exposed without having the PPE that is necessary, right? So many of the patients, they don't feel empowered to advocate for themselves and ask for that PPE. It's like, can I get a mask? Can I get gloves to perform better and safely? And so then the disease gets carried over to the house of the patients and to their friends. And there are many Latinos that don't wanna apply for public benefits, like Medicaid, for example, because of the fear of the public charge. So that fear is, if you apply for Medicaid, for example, and you are not a citizen, in the near future, when you apply for citizenship, you can be rejected because you applied for benefits before you were a citizen. Latinos that are not documented or Latinos that are not regulated, they don't qualify for the stimulus check. They do not qualify for unemployment, leaving them without a lot of resources to get food, to get the medication that they need, etc. For education, we have so many patients that let us know that they leave their kids that are like 2, 3, 4 years old alone in the house for their work shift because they have to work. Otherwise, they are not going to be able to sustain the family. And they're having some accidents with kids that have been left alone in the house, and that has been really challenging and difficult to address. For immigration, there are many cases that have been put on hold. And the reason why this is happening is because, especially at the very beginning of the COVID-19, our clients were not able to go to the USCIS office to continue their cases about immigration, and so they are put on hold. So therefore, many of them that were expecting like a green card and a work permit to begin to work, they are not able to do that. On a positive note, we have the CARES law that didn't provide additional funding for the ICEs and for the Border Patrol. So what that is doing is that the number of patients that are being deported is decreasing. We had cases where a mom and a dad have been deported during COVID-19, and kids that were like 16 and 17 years old with brothers and sisters that are like 4 or 5 years old left on their own. And so that's very painful to see. In terms of culture, the Latino community, they get really close to each other. They kiss a lot, they hug a lot. The number of people that is living on the household is larger than the average American family. So that is also a contributor for increasing the number of cases with COVID-19. Last but not least is the political situation. 4 years ago, when the political change happened, there were many patients that were working with us. They were very engaged. And so one of the cases, and then all of a sudden, all the patients disappear. One of the cases is this gentleman who was super engaged with us, working with us really closely. We called him, he didn't respond. We did a home visit. When we get to the house, he had been in a car accident, and he has been T-boned by another car. He broke his femur in 2 parts. His leg was of the size of my waist, and it was all purple, like bruised. He will not go to the doctor because he was afraid that he was going to be deported. So it took a huge effort to make sure that that patient went to the doctor and actually went to the emergency room. Everything went well, but still, because of the political issue, it prevents patients from seeking medical care. So how do we help as community health workers? How do we help these patients, our Latino community, to get the care that they need? So I'm going to read something real quick, which is the definition of a community health worker. It's a short paragraph, but a community health worker are trusted and resourceful individuals who typically come from the communities they serve. CHWs, which is community health workers, bridge the cultural and linguistic barriers, facilitate access to coverage and care, and improve health outcomes. Community health workers contribute to reduce health disparities, boost health and care quality, cultural competence and affordability, and empower individuals and community to feel better and to get better health. So that's what a community health worker is, somebody from the community who is going to be helping patients to get better, to become more self-sufficient. So we bridge the gap between the community and the medical and health system. So there are many organizations here in St. Luke's, in Wichita, that have community health workers, and each organization addresses the needs of the patient in a different way. So I'm gonna just go real quick through a list of things that we do to help those patients. This is not just our organization, it's many organizations doing different things, okay? So community health workers are connecting patients to medical services. So we get a referral from the health department, for example, and the patient doesn't have a doctor. So we are gonna help them. We're gonna teach them how to, set up an appointment. We're gonna go with them to those appointments, and we are gonna advocate for those patients at that time. There are several times where the medication is very expensive, and the patients are gonna not and get the prescription, they are not gonna refill it. So we advocate for the patients, asking for generics and things like that is gonna be more affordable for the patients. So as I said, we help with medication cost and also with medication adherence. making sure that the patients are taking the medication correctly, especially during COVID-19. Many CSWs are delivering food, cleaning supplies, masks, hygiene products to patients. There are the contact tracers from the health department that are identifying those patients. We get a list, we call them, we ask them what they need, we do an assessment, and then we make sure that they get all the resources that they need. We link Latino patients to behavioral health service and substance abuse service. Something that has been huge in the Latino community is the alcohol during COVID-19. There are many patients that have lost their job and they are drinking. And so they are with families. We are trying to get them together and get them to services that are going to help them with that substance abuse, and also patients that have depression, anxiety because of COVID-19 with behavioral health services. So we also link patients to financial assistance for medical bills, but also for utility bills. We have this is a huge number. We have a 30% of patients that have been referred to us that their power, the electricity or the water has been disconnected. And families that have babies in the house and not having like air conditioner or any kind of supplies for air and being comfortable in the house. We help patients to apply for benefits if they qualify for, unemployment, for Medicaid, for Medicare, Marketplace, etc. We help them with housing. There are many patients that have lost their housing right now. They have lost their job, therefore they cannot pay a rent. They are not going to have housing. We link them to projects that are going to help them with housing, especially if they are families. And we also, last resource, but it is also important, is making sure that they get connected with shelters if that's the case. And the last one is transportation. We help them to get to the medical appointments if needed. And we do cab vouchers, bus passes, gas cards, and making sure that at the end of the day, they become more self-sufficient and they are able to tackle all those needs and all those challenges as best as they can. So thank you for this opportunity.
Thank you, Tan. I really, gosh, that hit home on a lot of spaces that I personally cover as a journalist. And gosh, that was great information. And I hope that we provide ways for people to reach you all, even if they have questions after this. But we're getting ready to start our Q&A portion of our conversation today, which is really exciting. I had some early questions come in for all of you. And so I just kind of want to rewind and backtrack because I believe we still have lots of people on the line who may have some questions, and please drop the questions below in the Q&A box. But I just want to start off, Dr. Hill, this one's for you. There's a question in here that says that, are there any links to Alzheimer's and PTSD issues? Is there a direct connection?
Well, certainly more research is needed. I think it's a good question. And when you think about, Alzheimer's, the Alzheimer's Association International Conference just a couple of weeks ago, that Lancet International Commission on Dementia Prevalence, Intervention, and Care added 3 additional modifiable risk factors to their list of modifiable risk factors. So depression is one of them. Traumatic brain injury is one of them. What I think we're really heading to is that spectrum, that framework that I displayed that had a number of determinants along multiple levels of analyses that could play a role in the development of Alzheimer's or another dementia along the life course. And so as we're beginning to open that door, and again, this is the golden age of research. So many early career investigators are receiving funding to understand this link between a factor like PTSD or depression or some other type of psychosis and the development of Alzheimer's or another dementia. We're really at that time of exploring these relationships, and I'm excited about learning more and including diverse populations into many of these research studies.
Yeah, another question, and I'm going to actually split this into 2 because I think it's related to both topics, both COVID-19 and Alzheimer's testing, is for a lot of Black and Latino communities, there's just this idea of, you know, I don't want to know my status, whether that be as for COVID-19 testing, and also, you know, something like Alzheimer's. It's like, how do we get our loved ones to get past that barrier of maybe just not wanting to know and just going to the doctor and finding out? Because we do have caregivers on here today. We have people who are just curious and maybe even worried about their own health, as well as journalists who might benefit from hearing how you get past that. I just don't want to know. So I'll let all three of you answer that as it relates to your area. Yeah. Dr. Hill, you can go ahead, and then Dr. Echols and Tom, you can just go in the order that we went before. That'd be great.
Yeah, I think it's an interesting question around stigma, and you know what much of Dr. Echols mentioned and Tom mentioned around building trust and awareness in communities. So there's a research enterprise of a race for treatment and a race for biomarkers so that we can diagnose early along the course of the disease. But then there's an awareness, I think, campaign, that relates to public health and engagement, so that we can, kind of unmask, the stigma of Alzheimer's or other dementia, and understand how important it is to be under a doctor's care or to see a dementia specialist. So all of that, I think, is traditional public health, community-based engagement work, and being sure that we're providing resources so that investigators can partner with community-based organizations to do that work. Yeah.
Thank you, Dr. Hill. Dr. Echols, what would your response be to that as it relates to COVID-19? We have someone who is sick at home, or maybe even another condition or disease, but we can't quite get them to the doctor. What do we say? What do we do?
We have to put in a context where they can understand it. And so particularly for communities of color, they're very family oriented. And so putting in a context where, knowing your COVID-19 status can help protect you, your family, and your community is really what we have to emphasize. I think as Dr. Hill mentioned, so the stigma around not just testing, but just healthcare has really handicapped our communities. And a lot of that has happened because we haven't consistently and appropriately engaged them in a culturally sensitive manner. And so what we have to do is we have to do our work first to make sure that we're approaching them, leaving behind our bias and our hangups and our putting that on them. And so we have to, again, to make sure that we're doing our job, we have to make sure the messaging is appropriate. And also once we get them in our space, we also have to make sure that our staff are engaging them in a way that's appropriate and culturally sensitive. And that way we can continue to engage them, educate them, and empower them so that they can achieve optimal health.
Yeah, and I kick it to you. Yeah.
I completely agree with both Dr. Echols and Dr. Cole. And one of the things that is important too is the education. So is promoting that education, letting know why is this important. We do a lot of motivational interviewing. What is preventing you from not doing this testing? Why are you not doing it? And then also going to the sensible part, which is like, if you are not doing this for yourself, you need to do this for the ones that you love. Because at the end of the day, they are going to be affected as well. So that would be my response on that.
Great. Yeah, no, and I just thank you for your responses on that. And again, keep the questions coming in. I'd like to acknowledge that Affinia Healthcare, they've just wanted to acknowledge that they are on the line and they have people on today, and just wanted to give a thank you, particularly to Dr. Echols for the support and collaboration as relates to COVID-19 testing services, especially for vulnerable populations in the St. Louis area. And so thank you for being on today, and we'll continue with the questioning. And this one's from me actually. There's a history, and this is going to Dr. Hill, but also I think it relates, again, we could just kind of go around because we have some time here. There's a history of mistrust as it relates to testing, going all the way back to Tuskegee Project, which, if you're not familiar with the Tuskegee experiment, that was when Black men in America were told that they had bad blood, and ended up going into testing and had no idea really what was going on as it relates to syphilis. That syphilis was passed on to their family members and their children. There are still survivors, I believe, that are with us today, or at least not their descendants. But mistrust in the Black community, it goes way back, all the way back to that. And when I think about clinical trials and how important that is, Dr. Hill, and you still have people that are part of that old guard who just don't trust the system, how do we move past that? Because clinical trials and getting people of color involved, that's so important. But oftentimes we're nervous, we're scared, we don't trust the system.
Yeah, Cara, I think it's a good question. And, with the Tuskegee syphilis study, African American men were withheld treatment, right? And there was a treatment available with penicillin. And so, rightfully so, African American communities have a mistrust of the medical and research communities. And it's, as Dr. Echols mentioned and Tom mentioned, it's our job, I think, as a rigorous scientist, to understand how to address that trust. And Dr. Echols mentioned culturally aware, responsible, not just sensitive, but, kind of culturally, informed ways of engaging communities. And it's not a one size fits all, so we know African Americans in St. Louis, could have different sociocultural barriers and determinants than those in Atlanta, Georgia, from, where I'm from. So it's really understanding, taking the time to engage, making resources available so that researchers can engage, and then evaluating these strategies that are, I think, should be participatory in nature. And that means that, a researcher from the university should be able to work with a representative from a community-based organization to understand, this trust. And you don't show up with, can you participate in a clinical trial? That's not the first thing you do when you knock on the door. You try to understand, what are some of the needs of communities, and approach this in a very participatory, engaged way. So there's not an easy answer to that, Cara. I think it's more of taking the time to understand what the barriers are and to evaluate those strategies and reevaluate, and ongoing evaluation to create sustained partnerships.
Thanks, Dr. Hill. Ton or Dr. Echols, would you like to take a stab at mistrust? Ton, I'd be curious to hear from you as it relates to what's going on in the Latino community. I mentioned the project, but there's other things that have happened.
So for the Latino community, and I think that most of the patients, and I think this applies for the African American community as well, when you go to the doctor, you want to see people that is serving you, that is seeing you, that is like you. You know what I mean? You win the trust when you see a doctor in front of you that is Black, or you see the trust when you see a doctor in front of you that is Latino. And I think you get more trust from the patients when that's happening, which it doesn't happen quite often. So that's my point of view.
Dr. Echols?
Yeah, I think it goes back again to understanding the evolution of healthcare in the United States, particularly in the city of St. Louis. There was an article that was done by Dr. Berg from Washington University that looked at the evolution of health services for the indigent populations in the city. And so what it allows us to do is to properly contextualize the history, so we better understand where we are now. So there's lots of examples. The Tuskegee experiment is one that has made national headlines and is still talked about today. But then we have these minor incidents that don't get a lot of recognition. So just as Dr. Hill mentioned, how do we engage individuals when we're asking them to enroll in a particular study? And so that's been done for decades, and African American community has felt exploited because we've given our information, we've given our resources, but what do we get in return? And so one of the things that when I was in St. Louis County, one of the things that I made sure we started doing was informing the individuals about how their participation helps inform public health practice as well as medical practice, not only for the region, but potentially for the United States. And then also making sure there's a loop, a communication loop, so we can close the loop once whether it's a publication on the study, they need to be informed about, okay, this was how you empower the rest of us. This is how you empower these communities to advance in a way that supports the achievement of optimum health for all. So those simple things that we oftentimes don't think about will go a long way when we engage individuals to participate.
But if I could add, Cara, I think this one last question. I think we've spoken at length about the barriers, and they do exist. But there are many, in the Latino and African American communities, there are organizations that are trusted. There are organizations that have been in our communities for years. And if given the right information, right, and delivered in the right way so that people can understand, particularly as it pertains to Alzheimer's, African Americans are 2 to 3 times more likely to develop Alzheimer's or another dementia, but represent less than 5% of participants in the clinical trials. If we're able to say that in a way that really gets our community-based organizations, our fraternities and sororities, our churches, the Alzheimer's Association has a partnership with the AME Church, where we're really hoping to hone in on that message so that we can partner with a trusted community-based organization to get the word out about this important need. I think that we can make some progress. So I still have hope that we can engage communities. We've just got to be diligent and persevere and stick to it. Yeah.
Thanks, Dr. Hill. And I want to thank all 3 of our panelists for being here today. This is actually concluding our forum. We're right at 5:15. And so just thank you so much. If you would like to follow up, obviously, there's so many ways to reach everyone through Twitter and social media, and also, obviously the Alzheimer's Association's website. And thanks so much for being here today. And it was really great panel, and we're going to sign off for now. Bye-bye.